So this is a case I've done in a live case in Madrid in April. I remember we were together, and I think it's a nice case. And then we have at the end the case of yesterday, really fast. And this is a really young female with RCA CTO. It seems at the beginning that was only a proximal RCA CTO, and then we will see something different. And we can skip. This is the diagnostic angiogram. Sorry. Okay. We have this kind of proximal occlusion. It seems a competitive flow from distal, from left system, with very good many septal connection. Then they perform CT scan, and in CT scan we can see that we have two CTO, even proximal and this RCA. So that's why I start integrate. This is the setup from the. Okay, we can stop the audio. Okay, let's go. We can hear our comment. So this was the setup, and then I started wiring the first occlusion with had the E-long 2.6 and the NRH, the Lanson 3 gram was quite really 5 seconds, and we can. Yeah, because it was not possible to put the amplats left, and then because it was so, if you can see, it was so short. There's an anchor. Right. Look at. So the disease was progression. There was a progression on respect of the angio in August 2024. So we have a paraosteal occlusion, but we have this good side branch. So normally I take the amplas left, but this situation I try and I fail. I put you can see the GR4 with anchoring balloon. And I was able to wire, as I said, with the 3 gram Lancer and the long, and then it was quite easy to advance to the long. Yeah, spinning clockwise, as you can see, the spinning was really easy. And this is important, what Yasser was, the comment of Yasser. So if you want to use the GR4, because you have no space for amplats, always stay anchoring balloon. So it's really important to have a good support. Otherwise, if you advance the microcatheter, you lose everything. Then I did a tip injection that confirmed that was a double occlusion. I tried to wire the distal RCA with the distal lesion with the Lancer 3 gram. This was done. Yeah, during the live. You can see, but I'm not able to reach the. This is the reach Lancer 3 gram. I'm not in good position. Probably I'm in a side branch near the distal cap. So I switch with the Miracle Neo 3. This is a Miracle Neo 3. Try to advance to get, because I feel that I was really close to the distal cap. So I said that try to maybe with not with a polymeric wire I'm able to get the distality. There is not so calcified, so you can see there's not big amount of calcium, but the Miracle Neo went completely in a bad position. So I take Gaia Next 2, and this was the real-time crossing of the Gaia in the posterolateral branch. We are in this position, and checking from the left, we are in the posterolateral branch, and then I take dual lumen. So classical strategy. So take dual lumen and the Sion wire to get access to the PDA, but the Sion doesn't go because probably I jumped the bifurcation. So I went subintimal at the level of the cracks. Shevket, what's your comment on that?
Yeah, I think so. It looks like if you cannot go with the Sion wire into a lot of branches, it could be, but you should need maybe another, look it from a different
And this is something that we often we have this kind of strategy situation. So we puncture with the steel wire with the Gaia. We went in the good loom and distally, but we jumped the bifurcation, and then we are not able. So we need to puncture again, or we need to do something different. So in this situation, I switch to retro, and this is the Elong 2.6 and any reach 0.3 P, and this is a real-time crossing. Actually, this was a long 0.3 P because they didn't have the short one.
Yeah.
So I say, okay, I want to use even in the long wire, but it was the 300 centimeter wire. But you can see how easily the 0.3 was able to cross. The advancement of the Elong was quite easy. You can see here spinning clockwise as usual. You can see the guiding catheter. Try to go back. So it's really important because often I think that even in your experience, when you are proctoring and the operator is not able to advance the microcatheter, no, I think that happen quite often in your experience. And then you come and you and you push and say, oh, why? Always. This is something that you need to. I'm using both hands. I'm left-handed, so I'm using a lot the left hand. So left and right. And the first point is always get the guiding catheter in a good position. So have a good support with the guiding catheter, and then use both hands. One with you spin with the right, you push with the left, and then you are able to cross with the microcatheter. Then this is the crossing with the 3 gram any reach 3 Lancer. The retro crossing was quite easy. In the second occlusion, you can see here was a real time crossing. You can see. Okay, we are in a good position, and then at this point we need to enter in the GR4. In that situation is also really useful to have an anchoring balloon that can help you to modify the position of your guiding catheter. And then what even Yasser show you that in this situation, I use the T-pin technique. And then distal rendezvous, you can see here. So this is not, we are not obliged to do that. So it's not mandatory, but if you are able to advance your antegrade wire in the retrograde microcatheter, you increase a lot the support of your wire. It's like an inverse retrograde from antegrade to retro. So you have a huge support putting the antegrade wire in the retrograde along. It's not necessary, but you can do that. That I was able, so we have 2 antegrade wire here, and I was able to perform a kissing balloon. And this is the IVUS. So the IVUS run is interesting because you can see coming the posterolateral branch since 2 o'clock, and then you have a big hematoma distally. We can do again. You can see again. And we have still, something to fenestrate. So in this situation, Safket, so which are the strategy we can use to do this kind of, to save posterolateral branch? Because we know that we are true from the PDA, and we jump the bifurcation at the level of posterolateral branch. So which is the so we need to save the bifurcation. So I did kissing balloon, and we have still this kind of still a small flap to fenestrate, exactly. So you can see here. You have, this is the wire coming from the postural branch, and this is the wire in the PDA. And you can see here again, you will see the wire coming in the postulateral branch here. And then you can see we have the subintimal space at the level of the cracks, and then we are really close. Yeah, but is important. This is important point. But from which wire?
But you can do crush stenting, don't you?
You can do mini crush stenting.
Mini crush, and you will be 100% sure that
exactly,
you will be in the true mass.
Exactly. So one point. The second one, the cutting balloon is good, but you need to use in the PDA wire, because you need to cut from the true lumen to the false. Okay. If you use the cutting balloon at the level of the posterolateral branch, you think, okay, I want to fenestrate, so I put a cutting balloon at the level of PL. Is not useful, because you need to fenestrate from the true lumen PDA exact for the true to the false. Yeah. Okay. Or use reverse wiring. So you put the dual lumen, and then in the PDA, and then you reverse wire in the posterolateral branch.
I think some operator think it's okay, the flow is okay, but I think it's not. If you draw your wire, the doma will increase, and the flow in the side branch will not be okay. So I think it's very important.
It's an important point. Yeah, I did something different, because it was I take a retrograde wire. You can see here. Again, from D long, you can see I went into the posterolateral branch. So we have one wire in the PDA, one wire in the PL. That is a Sion, because I switch, and then we did a retrograde wire again here. And I've seen that first the wire in the PL is in the true lumen, just beyond the bifurcation. We have, you can see here, this is important point. You can see we have a like 3 millimeter of, exactly. So this is nice, because we have a sort of triangle. You can see here, in which we have the PDA is all true. The antegrade wire in the posterolateral branch is subintima at the level of the cracks, and then is true, and the retrograde wire is a marker and go close to the antegrade wire in the PL, really 3 millimeter after that. So I agree with the Yasser that normally I like to do mini crash in that situation, even if here, when you do that, it's sometimes really complex to recross the wire, because you have always a sort of flap in between the two stands. So that's it. In that case, we discussed a lot with Pablo that we were together. We didn't want to do two stenting that. So I repeat the kissing balloon with much more overlap back. Okay, you can see. And this was a cutting balloon in the PDA. So I did a cutting balloon in the PDA, and then kissing balloon in the posterolateral branch. So
okay? Here in this case, generally what I'm using, I would have stand from the cracks towards the PDA. Okay, then I would do here with a bigger balloon, a jailed balloon technique. So I have still my wire there, okay, in the branch, in the PL branch. And after that, I would check the flow of the PL, and if it's necessary, would do a provisional kissing balloon technique. And if I have a good flow, then I would maybe end with a drug-coated balloon. It depends on the TIMI flow. If I have a TIMI 3 flow, even in that kind of scenario, I would leave it like that.
We have a comment from
Yeah, if in this situation, retrograde wire can go to PL, I will use kissing balloon technique
from the retrograde.
That's right.
That's right. That was a point that go on with the comment.
If we use the integrate balloon and kiss the retrograde balloon and make the PL the intro bigger, it quite easy, and maybe it is depend the angiogram and the results. If the angle is very acute, you can use double lumen catheter to do the reverse wire technique.
Exactly. So the point of because we thought about doing a cart, so ballooning from the wire retrograde, so removing the long, putting balloon, but here you need to think about that. So at the level of carina from retrograde, you have true lumen. You have true. So it's not so necessary to ballooning retrograde because you have the true. So from the PDA to the postlateral branch, we have the true lumen. The problem is proximally. Okay, I use this technique when I need to puncture the posterolateral branch with a stiff wire, and then I put the balloon modifying the distal cap, and then going with the wire towards the balloon inflated. But in that situation, I didn't find so useful because we know that this part, just to explain, we know that from retrograde, this from the PDA in the posterolateral branch is a true lumen, so we didn't need actually to balloon too much. So in that situation, I repeat the kissing balloon with the cutting and the classical balloon on the posterolateral branch, and then we didn't want because of time to repeat the IVUS. This is it's a pity because if we're able to have IVUS here, we will see that we have obtained a fenestration. After that, we put stenting from PDA in crossover. You can see here, and this is we recross after stenting the posterolateral branch with a Sion easily. We did kissing balloon, final kissing balloon. So we didn't stand the posterolateral branch, and this was the really good final result. And you can see here we have the two flap. That is, one is the wire that is outside subintima, and then the other wire that is exactly in the good position. So we have very good. You can see here.
This is okay.
Perfect result.
So I have a question for you, Roberto, and to Yasser. So you had an anchor balloon there, okay, and then I just want to know your experience regarding spinning the along 2.6 French down. I have always the feeling, compared with the other coiled microcatheters.
Yeah.
So I have the feeling that as soon as I begin to rotating, I feel extra support also on that guiding catheter. I don't know whether you guys feel the same. So when I go into the lesion and begin, the energy that's building up on the front of the microcatheter will not push the guiding catheter out of the vessel, rather than transferring the energy more forward, and then it's just having this kind of movement of the guiding catheter, and then it goes further. So this is what I am. And with Tippen, I never, after Tippen, had the difficulty crossing antegrade. Sometimes it might not work, and then you have to increase the support of your antegrade microcatheter. But with this one, I do a lot of Tippen. I have almost not doing externalization anymore. And with this one, I had never a difficulty. So I just want to ask your experience about this.
No, I agree with you. So I think that with this microcatheter, it's really important the first like 20 millimeter of of crossing. So if you're able to advance, then you increase your support even to go distally. So this is a really, we have the same feeling on that. So we have a great support, great crossability, and then we are waiting for the new edition. So if this is so good, will be the other one will be much even better.
I
So,
doubt that.
so I think that this is a very good point. So always take good support with the guiding catheter, but then this microcatheter is really great. So let's go really fast to the case of yesterday, because this is a huge calcified RCA with anomalous origin. You can see the very poor backup support, complex epicardial connection. You can see here that the takeoff of the epicardial is really bad. Is proximally to the circ, and then 90-degree bend, and then we have three branches that here is not easy to understand. Then we start. This is the left injection, and we can see that we have only this epicardial connection. We have 1, 2, 3. The small one was probably the best, but really complex to for the takeoff. And then we have the other one that is the long one. You can see here that we lose this part. So we start antegrade, but because of support, because of the calcium, we were not able to advance. You can see here trap liner, and then even nothing to do with this antegrade approach. Then we did to switch retrograde. Was at the beginning impossible to take access to the epicardial, so we need to take a dual lumen. So this was a Sasuke, and then at the end I was able to advance the Sion Black over the Sasuke here. I think we can see. You can see here, okay. So we are now in a good position with the Sion Black. No CC0 trying. No, because if you can see, this is really important. When you see the angio, you can see all the flow is from the epicardial. We have nothing coming there. Probably maybe we can try the CC0. Okay. You would have tried the CC0. But, yeah. But this situation I didn't try that.
But I think the reason you use the epicardial is you wanted to put all your energy on that calcification. You know that you would be there in trouble. Instead of losing time there, you choose the epicardial.
That's something that I thought of that. And then, so this is the angio to show this kind of tortuosity here. This is SUO3. So SUO3 crossed the first part, and it was good. Here, this kind of tortuosity here. Look at. And then I failed with the SUO3, so to advance. And this is what I told you before. You can see with the SUO3 is make a sort of twisting. Yeah. Okay. And I was really close with the microcatheter, but nothing to do. So I try to be gentle, but I have this kind of behavior with the SUO3.
And if you knuckle, then you are done with SUO.
Exactly. Yeah. Exactly. So this, and then we have one piece of 0.3 any reach P in that lab. I say, okay, I want to try that because we need to do something. Look at, this is a real-time crossing with a 0.3 P.
And the beauty is it get not destroyed so easily.
It was amazing. It was 10 seconds. You can see that. That's why I say, okay, I need to show tomorrow. So this is again. So the same microcatheter, the same position, I went there easily. Then I advanced the microcatheter. I check for sure. I advance. I change the band of the any reach because I had to go on the left. You can see here. Then retrograde crossing, ballooning. So it's a mix of probably contemporary reverse card because I balloon antegrade and then I was able to re-enter. And then we struggle a lot with the retrograde wire. And then this is the IVUS that show huge vessel with the really big calcification. You can see here. So we did a lot of work on that vessel, and then with the shockwave, with ballooning, cutting balloon, and so on. And then we have a great result. So, but this was just to show you the concept of something that we didn't have in the past, but this kind of work can help us to do probably something that otherwise was impossible.
Yeah.
So I think that we did a great session. So thank you for all the speakers.